I started researching the COVID situation and thinking about what scenario we'll face going forward since around the end of March. And it originally started because I was hoping that I could understand for my own benefit what we will need to live with for any short or longer period of time. This talk is different from most usually upbeat technology-oriented talks at the Samsung Forum. Now, for starters, it's obvious that I'm not standing in front of a live audience, but that all of us are looking at and listening to a screen from the safety of our homes. And if the projections I will share with you today come true, then this situation, with some modification going forward, will continue for quite some time. And my hope for this talk is that you all will walk away realizing that there's a real need and a real opportunity to develop and deploy digital applications and platform to mitigate the effect that COVID-19 is having and might continue to have on our social lives and the business world, and that your work can make a real difference in this. With this, I want to start and tell you that what I'll show today is my take on different COVID-19 scenarios and my belief which is the most likely scenario and what insights and what recommended response would derive from that scenario. And I structured this talk in three categories. I first want to talk about the current status and hypothetically possible COVID-19 scenarios. Then I'll tell you what I think the likely scenario resulting from data and assumptions is in my view. And lastly, I'll lay out what I think a good strategic response under this scenario will be and show some implementation examples of some meaningful measures that are already in place or in development under a scenario like this. So before I go into the current status, let me put this in context. The situation is obviously bad. And I sincerely hope that everyone who is listening today has been affected by the social implications, but none of you or your family members have fallen sick. But it touches all of us and many people that we know. But let me put this in perspective. CDC, as of yesterday, we had around 92,000 deaths in the US. And we are not through the first wave, so there will be more to come. But I think what few people know and realize is that in 1957-58, we had an influenza pandemic that killed 116,000 Americans and more than 1 million people worldwide. We don't have to go back to 1918 to look at a really bad pandemic. This has happened in more recent time. It doesn't take away from the fact how difficult this is and how devastating this is in all aspects, but I think it puts it a bit in perspective, especially when we ask ourselves the question, will we go back to a normal and what will the normal be? Obviously, after 1957 and after 1968, we very much went back to a normal as things had been before. So let me now go to what is the current status. The good news is that the COVID-19 curves in the US and in many other countries, but I'll focus on the US in this talk, are flattening. And what you see here is a curve I'm sure you have seen, which is the typical cumulative, here it's death cases, plot on a log scale. So we have seen that COVID pandemics grow exponentially. So on a log scale, you have a linear trend as long as the growth rate remains stable. And that's the situation we had at the end of March with a fairly steep trend. And some people did this, you did a visual extrapolation of the growth at the end of March and just extended the line. That's where you would have expected, and some people projected we will have more than 100,000 death cases by mid-April. The good news is, as you see, the trend didn't continue on this straight line, but it started to flatten. And we appear to be at or past the peak of the daily cases and death for this first wave. Now, I want to talk a little bit about tracking metrics, because I think this curve, while it's good to extrapolate a constant trend, is a really bad metric in order to look at changes in the growth rate. What you see in early April is that you actually had an initial deviation from the straight line growth trend that resulted in a flattening of the curve. The problem is, on a log scale plot, you very small changes from the original linear growth actually have a major positive effect on the number of go-forward cases. But because of the scale, it's very hard to see that we are actually deviating from the original linear trend. And you see the dots at the end of March, early April, just slightly running under the linear extrapolation. But the impact this had was a fairly big impact, which I'll show you in a minute. I think when we look at the dynamic of exponential growth, a much better way to monitor changes is by tracking the number of days it takes for the death count to double. That's correlated actually to a parameter of the exponential function. And it's, if you will, equivalent to the very intuitive half-life parameter of exponential decay. It's like the brethren of the half-life on the other side. And so when I realized that we were seeing improvements in the trend that was barely visible and recognizable in the traditional log plots that everybody was looking at, I started to track the doubling time for death cases in the US. And if you go all the way to the left of this curve at the end of March, you see a doubling time of around 2.5 days. And that's a really bad doubling time. If you look at the insert on the right side, if you start with 10,000 deaths on day one, then at a doubling time of 2.5 days, which we had end of March, 10,000 deaths will grow to 640,000 deaths in 15 days. So that was underlying some of these very bleak-looking projections. But as the curve on the log plot started to slowly deviate from this trend, you could see that the doubling time more or less constantly started to increase. There are some fluctuations in the curve and some aberrations when it comes to reporting. There's a spike every 7 days. But if you smooth this out, what you basically see is a dramatic improvement of the doubling time since the end of March. And this is for the entire US, so you obviously have some states that were affected earlier and then got better, and some states that were affected later. So you see the blended effect of the entire United States. And if you look to the right side at mid-May, we were at 37 days of doubling time. And the same 10,000 deaths that would have grown to 640,000 at 2.5 days, if that had continued, would now only grow to 13,200 deaths. And as you see, as of yesterday, we achieved a doubling time of around 48 days. So there is a major improvement, a flattening of the curve, and it looks as if we are getting through wave one. Let me talk a bit about a parameter that you might have read about, which is called the virus reproduction numbers. And there are two. One is R0 and the other is RT. R0 is what's called the basic reproduction number. It's essentially how transmissible the virus is based on its biology. And on this chart on the left, you see some examples where for seasonal influenza, it's between 1 and 2. And for coronavirus, it's been estimated between 2 and 3. And what this number means is, on average, how many other people does one infected person infect? So you see the red person at the center of the circle and the other people around. And this one person with seasonal influenza would infect, let's call it 1.5 other people. With COVID, it would infect 2.5. And so it easily becomes obvious that if this value is above 1, the disease will spread exponentially. And what we need to achieve is we need to push this number below 1. The moment that the reproduction number goes below 1, the disease will go away. Now, I said there are two numbers, R0 and RT. R0 is the biologically inherent reproduction number. It's how bad the virus is. But RT is the effective number. In the real world, where we have eventually immunity and also containment measures, let me give you an example. If what we're doing right now, you take the circle around the coronavirus patient, which has 20 other people around them. And if you take 15 of these 20 people out of the vicinity, then this person will not infect 2.5 people. Or if 10 of the 20 people had natural or vaccine-based immunity, the person in the middle would not infect as many people. Or if everyone in the circle was wearing masks, that person would also infect much fewer people. So the RT value is the really interesting one, that given all the measures we are taking, shows what the reproduction number is. And as long as it's above 1, we will have exponential growth, which means from one person, it can infect the entire population of the world. If it goes below 1, then regardless of how many people are infected at any point in time, the disease will go away. The ideal metric to track coronavirus would be RT. And RT would be ideal to show where we stand and also what the effect of either containment measures or the reopening of the economy and our social lives is. However, the problem is RT, as useful as it is incredibly difficult to calculate, because in order to calculate it, you need the number of cases. And that estimate is highly dependent on the extent of testing, which has varied over time. There is a website, rt.live, that I want to just share with you here, that was launched by Kevin Systrom, one of the co-founders of Instagram. And that is showing real-time RT values, daily RT values for all states. And you also have graphs for states over time. So that's a really interesting metric to look at and also see the time course. I just want to point out, given the challenges, they have changed the model a couple of times. There's actually a comment on this graph even that as of yesterday, they updated the model. And the challenge is that, as you see, most states here are below the 1 with their point estimate, which is good. They're very close to 1. And if the model estimates it a little off and we are above 1, then we're in a very different territory. But it would be the perfect metric, not only to track, but also see the effect of measurements or reopening. Just want to point out the Hong Kong University School of Public Health has an RT tracking up since January, and I'll actually show you how relevant and how useful this is in a few slides. So this is where we are. We are at or past the peak of the first wave. The question is, where can we go from here? And this list has my view on hypothetical COVID scenarios, and only one of those I think is realistic. The first one, hypothetical one, is full containment after the first wave, which happened with most previous pandemics, where after the first wave, as bad as it was, we had the disease fully under control. The next one is we have reoccurrences, but they're either minor, regional, or seasonal. So, for example, in the fall, but they don't lead to a complete pandemic that could affect everyone in the country. The third one is a scenario where we have to actively do something. We have to pursue an active containment of subsequent waves through targeted interventions. And if we don't, then the second wave could become as bad or almost as bad as the first wave. And then the last one is the doomsday scenario. It would assume that there's an unmitigated spread with morbidity and mortality in subsequent waves. Let me now tell you what I think the assumptions would be that would make you believe that one or the other scenario comes through, and then show you some data and tell you which scenario I think we'll be facing. In the first scenario, the full containment scenario, you would have to assume or achieve that the effective reproduction number, this RT, consistently drops below 1. You could get this if you have sufficient natural herd immunity. You might have heard this term, which means enough people in the population are immune that the virus cannot spread exponentially any longer. Or we could have an effective vaccine that leads to the same effect, enough immunity, not naturally developed, but through a vaccine that is not only developed, but also broadly deployed. Or we could have antiviral drugs that are so good that they contain and mitigate any residual outbreak. So we might have outbreaks, but we get them under control really quickly. The minor reoccurrence scenario, that would assume that the reproduction number RT rises above 1 in certain communities or under certain conditions, like the infamous fall epidemics, and that the herd immunity, either naturally or through vaccines, is not complete enough to prevent any outbreak, but is sufficient to contain it, so that we peak above 1 and then it drops below 1 and it goes away. Maybe in combination with antiviral drugs, maybe in combination with what's called non-pharmaceutical interventions, all these stay at home, wear your mask, non-pharmaceutical measures. The third scenario, active containment. The assumption would be the virus reproduction number retains the potential to rise above 1 and then trigger exponentially spreading resurgences for an extended period of time. And that would probably occur if vaccines are not available for an extended period, and I put 12 to 18 months here. If the available antiviral drugs prove not sufficiently effective, but the combination of digital tools, diagnostic testing, and other non-pharmaceutical interventions, like broad usage of masks, control of inbound traffic, result in an effective monitoring and quick containment of outbreaks. And then the last scenario would mean the virus reproduction number remains much larger than 1 on a large scale, which would lead to an unmitigated and completely disastrous public health outcome. But the assumption here would be essentially that the full-scale non-pharmaceutical interventions that we know are effective, because we have managed to get through the peak of the first wave almost in every country by now, that these effective non-pharmaceutical interventions are essentially abandoned across the globe. So these are my 4 scenarios and the what you would have to believe assumption that would support either one of those. Let me now show you just some data and some facts to get together to a point where we can decide which scenarios the most likely one will be facing. I'll want to start with 2 pandemic expert sound bites. The first one is from a publication of a Harvard group from earlier this year. And the essential statement is the one in italics, which says to avoid this, which means a continued spread of the disease, overwhelming the healthcare resources, prolonged or intermittent social distancing may be necessary into 2022. And the last sentence here, the surveillance should be maintained until 2024. So that's a long-term perspective. Now let's look at the quote that is from 2007, so not informed by this pandemic, but based on the experiences with the 1918 Spanish flu. And the authors also talk about non-pharmaceutical interventions, and they state that in the event of a severe pandemic, and I think COVID-19 qualifies for a severe pandemic, cities will likely need to maintain NPIs, meaning social distancing, wearing masks, washing hands, and all the other things we are doing, for longer than the 2 to 8 weeks that was the norm in 1918. So these sound bites, one from the past, one from the present, don't look as if pandemic experts believe that this can be over anytime soon, or as soon as we get through the first wave. Let me talk about immunity, and I want to talk about herd immunity first, and then natural herd immunity first, and then vaccine-based immunity. This is a paper that looked at estimates for the coronavirus RT values in different countries. And RT, as I mentioned, is difficult to estimate because you need a denominator, which is the actual number of cases, which is difficult to know, especially if your testing dynamically changes over time. And you see a fairly wide range, but the range that's most consistent with what I've seen experts assume that RT is the middle block, the RT of 2 to 4. And so for RT values in the range of 2 to 4 in different countries, this group estimated in the rightmost column what the minimum proportion of the population is that need to be immune in order to stop the spread of the disease, meaning to drive RT below 1. And you see that at the low end, the number is 56%, at the high end is 75%. So between half or 3/4 of the population need to be immune in order to drive RT below 1 just through the natural immunity. And we are far from this, regardless of how many cases we are, how many asymptomatic we are far from 50 to 75%. So the takeaway from this is we cannot rely on the natural development of herd immunity for a virus that is so contagious, means easily spreads from one person to the other, and so virulent, meaning extremely severe and harmful. If it was not contagious, we could probably work through this and it would take a long time. If it was not virulent, meaning harmful, we could accept that most of the population get the disease if nothing bad happens, but this can rely purely on herd immunity. So then what about vaccines? Here's the bad news. In all publication and references I've seen, the consensus is that large-scale vaccine deployment will take at a minimum 12 to 18 months. And the main reason is not the challenges in developing a vaccine and getting this through the FDA. That's difficult enough. But the challenge is the availability of large-scale manufacturing facilities. What the table on the left side in fine print shows, and the main column is the one with the orange arrow pointing at it, that for simple vaccines, inactivated vaccine or live attenuated vaccines that work for many other conditions, we have sufficient manufacturing capabilities. But for the more complicated biotech vaccines that in all likelihood we will need for COVID-19 or the SARS-CoV-2 virus, these manufacturing facilities have not been available on a large scale. And pharmaceutical companies are ramping up not only the development, but also the manufacturing. But on the right side, you see a projected timescale, and this is from a scientific publication. And it shows that with the bottleneck of the manufacturing facilities that allow a deployment of vaccine to the tune of 50 to 75% of the population, the expectations are that this is 12 to 18 months out. So that means end of 2021. Now let's look at what one of the major pharma companies is projecting. There was a widely publicized presentation from Johnson & Johnson recent earnings call about a month ago. And when you just look at the title, it looks very promising. They're doing the right thing, accelerating R&D and manufacturing in parallel to get to 1 billion doses. And then the chart ends with Q1 2021. And many people in the press have picked up on this and saw this as the projection that by Q1 2021, J&J alone will be able to provide 1 billion doses. Unfortunately, that doesn't seem to be the case. Around the same time of this earnings call, their J&J chief scientific officer gave an interview, and he stated that they plan to manufacture between 5 to 10 million vaccine doses by early 2021. So that the early availability, and the chart is actually correct, just people drew the wrong conclusion from two numbers that were not really related to each other, the 1 billion doses and the Q1 2021. And so the first batch of doses will probably do a good job in vaccinating healthcare providers, and that's a good thing. But Paul Stoffels estimates that J&J should reach 100 to 300 million doses by the end of 2021. Now, keep in mind, that's probably not for the US alone. That's probably for worldwide supply. At the same time, there are other companies working on vaccines. So you could estimate to get to a point where we're approaching the necessary level of herd immunity at the end of 2021. The billion doses, it looks, will take until at least 2022. But this data supports a view that the large-scale deployment that we need in order to get to the necessary immunity is still 18 months out. What happens as long as we don't have herd immunity, and what is the risk? And a good example is what happened in Hong Kong in March. In Hong Kong, when when they relaxed some of the original containment measures, there was a quick and exponential resurgence of cases. And they got it under control by putting those containment measures back in place. And I know that some of the cases, the initial ones were probably imported cases from people traveling to Hong Kong. But you see in the chart on the bottom where the imported cases are the blue color and the local cases are the reddish color, that it quickly spread to the resident population and continued growing exponentially there. And what's really interesting in this chart is when you compare the lower graph, which shows the number of cases, with the upper graph, which is the Hong Kong University estimation of RT. And you see what happened as this resurgence occurred, that RT went above 1 again. And then as they managed to get RT below 1, the cases dropped. What this shows is that the virus retains its potential to quickly go above an RT of 1 and spread exponentially. And the only thing that so far has been containing it has been the non-pharmaceutical interventions. So let's look at the 4 scenarios again, and here's my take on how likely they are. I don't think we can, under any scenario, expect the first one, the full containment after first wave. It's just not realistic given how aggressive the virus is, and that we don't have vaccines or antivirals available at this point. That would, by the vaccines certainly, and then the antivirals by themselves contain it. I also do not believe that what happened in most other pandemics outside of maybe 1918 occurred, which was a recurrence that was self-contained, minor regional or seasonal occurrences. And the reason is that we do not have, for some time to come, a sufficient herd immunity to limit those follow-on outbreaks. Let me jump to the last scenario. That's also not going to happen. We will not let the entire population die, because we know, as painful as they are for social life and economy, we will not have to accept an unmitigated spread, because we know that the shotgun NPI measures are effective. So we will not let this happen. So that leaves us with the third scenario. And I think that is what we have to expect, that for some time to come, if you just look at the vaccine timeline, then this could be easily the rest of this year and the majority, if not more, of 2021. We will live in a world where we have to balance the virus containment and economic and social restart, and where we'll have to have an active containment of subsequent waves through targeted interventions. Hopefully not in this black and white, we shut everything down, we open up, we shut everything down, we open up. But we can expect that the subsequent waves will not be self-limiting, but that we need to actively work to keep them and get them under control. This brings me to the last part of this talk. How could a strategic response look like, and what would be examples for an implementation under what we probably will have to face for an extended period of time? Let me start by saying there's still quite a bit of balancing of the social and business environments between active containment and subsequent waves. These two images are pretty much from the same time. The left one shows a design study from an Italian aerospace company, where you see their vision of the plane of the future with the middle seats facing the opposite direction. And it's hard to see in the image, but you have plexiglass dividers going all around. And obviously the flight attendant wearing masks. So this is one end of the spectrum. The other end of the spectrum is an image from Huntington Beach in California from end of April, when honestly, if you had shown me this picture, I couldn't tell you that this was during the coronavirus pandemic. So there is still quite some wiggle room between the extremes of a scenario. But I think we'll have to find the balance and have some of the left side and some of the right side. We will not completely go to the left side, I hope, and we will certainly not have the opportunity to completely go to the right side. Here are 6 objectives I believe we need to achieve in order to manage through this scenario: the active containment of subsequent waves through targeted interventions, where we balance the containment with the restart of our lives. The first objective is fewer in-person contacts. Think of the graph that shows the RT concept, with the one infected person in the middle surrounded by, in that case, 20 other people. As I said back then, if we only have 5 people around this person, there will be less infection and a reduced spread. And I think this needs to continue for some time. Not a single of these measures, until we have vaccines, will by itself reduce RT below 1 and lead to a full containment of the disease. I expect that we need to do a combination of those, and by having fewer in-person contacts, we drop RT by a certain amount, not below 1 probably, but close enough that some of the other measures in orchestration can get this achieved. So I expect that we will continue with remote work. We might have office situations where a third of the people come in Monday, Tuesday, the next third on Wednesday, Thursday, and the last third on Friday, Saturday. We will have video and web meetings. We will have digital conferences. We will have occupancy reductions in offices and restaurants. We will have fewer in-person contacts, because that's one really easy, even if inconvenient, way of reducing the spread. Where we have to have in-person contacts, we need to lower the transmissibility. So we still meet the other person, but the chances of us getting infected if the other person carries the coronavirus gets reduced. For example, by using masks, by having mask sterilization systems that allow us to reuse masks, which are still in short supply, by having physical distancing and physical barriers, by potentially having health status-based location access, which is what people have been practicing in China, or by having an immunity IVD test that shows us that people have contracted the disease and are immune against the disease, and therefore cannot be infected in an environment in which otherwise they would. The third one is early detection. So even if we have fewer in-person contacts, even if we reduce transmissibility, some people will get infected, and the sooner they get detected, and as I'm sure you've read, the challenge with coronavirus is that people are contagious, so can infect others before they themselves have any symptoms of the disease. That includes digital symptom monitoring, health status tracking, but also diagnostic and surveillance IVD testing to find people quickly if they have contracted the disease. The fourth one is for those that actually get the disease going forward. We need some effective quarantining that involves contact tracing, but could also involve prophylactic quarantining of inbound travelers. You've seen that inbound travelers probably triggered the March resurgence in Hong Kong, and regions and countries will probably be very concerned about letting people with unknown coronavirus status into the country without quarantining. The fifth one is more on the side of the pharmaceutical and biotech industry, an early availability of vaccine and antivirals. That could involve AI-assisted drug discovery, but it also means a rapid scale-up of vaccine manufacturing facilities, which seem to be one of the major bottlenecks. And then the last one is, as long as people will still contract the disease and will add to the burden of the healthcare system, it would be very helpful to have efficient healthcare services, meaning continuing with the video consultations that we have now used on a much larger scale, using automation in healthcare system supply chain management. We still have some ways to go. I would like you to first read what's in the table in the chart before looking at the title, because when I read it for the first time, these non-pharmaceutical interventions look pretty much like what we are doing today. One of the takeaway on the left side is dance hall closures. I didn't realize that they were still popular. And on the right side, the ban on door-to-door sales. And these giveaways show that what you're looking at are the 1980 non-pharmaceutical interventions. And I found it very interesting that the majority of the non-pharmaceutical actions we've taken in 2020 are not much different from what people did literally 100 years ago. So there is absolutely some room for improvement in my view. The measures that I think will be most useful to achieve these 6 objectives: fewer in-person contacts, lower transmissibility, early detection, effective quarantining, earlier vaccine and antivirals, and efficient healthcare services. I think they fall into 4 categories. There are physical ones, digital ones, diagnostic ones, and pharmaceutical ones. And the digital ones are probably most relevant and interesting for this audience. The physical ones involve, for example, plexiglass barriers in restaurants or in retail stores. But the digital ones and the physical ones apply for some of those objectives. The diagnostic ones that can help with lower transmissibility and early detection help with some of those measures. And the pharmaceutical ones certainly are focused on the 5th one, the earlier vaccine and antivirals. But interestingly, as I thought about this, the digital measures, they can actually help in all of these 6 strategic objectives. And I only listed a few examples in the bottom. It's actually a long list for each category, but especially for the digital measures, that we can actually achieve these objectives that help us to contain a not self-contained virus for the time it takes until we have enough vaccine coverage and immunity. And these digital measures are the ones that should differentiate what we do in 2020 or 2021 from what we've been doing in 1918. And so far, as I showed you, most of what we're doing today is very similar to what people had done in 1918. So there's a lot of opportunity and a real need to develop and deploy those measures to help with all those 6 steps until we get to the vaccine stage, and that means broad deployment. We will need a combination of all the other factors in order to reduce the spread, to reduce the transmissibility to a point that it's no longer spreading exponentially, but any reoccurrence is quickly contained, detected and contained. For the last part, I just want to show you some implementation examples. The previous chart had a lot of bullets and graphs on it. These are real-world examples of they fall into most of those first categories. The fewer in-person contacts, here's a design for a 6-feet office at a real estate firm in Amsterdam. You see spacing of desks, you actually see plexiglass dividers. Fewer in-person contacts. Conferences are already going digital. TechCrunch Disrupt, which has always been a big in-person event in San Francisco. Now, at the time I put this together, still had the option of an in-person ticket, but they also offered what you see in the lower right, a digital pass. What we need to achieve is that the digital conferences are not just webcasts of the physical conferences. The ones that I attended in the last weeks were not very engaging. They were just streams of what otherwise would have been on stage, and it's really hard to maintain the focus and to have any sort of engagement. So some enhanced digital engagement features would make a big difference for something that I think, either because we have to do it or because people feel more comfortable to attending virtually, will stay with us for, I think, quite some time. Fewer in-person contacts doesn't have to be high-tech. This is a low-tech implementation out of a Starbucks in Hong Kong. They didn't even have to move the chairs and the tables into storage. That is something that helps in the first category to make sure that the person sitting at the table on the left side doesn't get infected by someone sitting right next to him. The lower transmissibility, this is a paper by Jeremy Howard. They did a review of papers on the effectiveness of wearing masks. And I know we have heard conflicting stories and changing stories about wearing masks or not wearing masks. Let me give you my take based on my medical and clinical background and understanding. This is one of the most effective measures. And I think you should look at this not only for the application of a person who has coronavirus to protect the people around them. I also look at this as something that protects the non-infected person wearing masks. And in this paper, they quoted this graph with these isoclines of RT numbers. So the curve that says 1 basically shows under which conditions you are above or below 1. And what you see is that with a fairly high efficient mask and only 50% of adherence in the population, that alone would drop RT below 1. If enough people are wearing less efficient masks, you don't necessarily get to a reduction below 1. But as I mentioned before, the combination of fewer in-person contacts and different measures of lower transmissibility, and wearing masks is one of those. In aggregate, we can get RT below 1 and get the disease to stop. So if you walk away with only one takeaway from this talk, I ask you to remember that wearing masks is a highly effective way of reducing the spread and protecting yourself. A lower transmissibility, that's actually a real photo out of a Hyundai cafeteria in Seoul. Obviously, people cannot wear masks when they have lunch. So you have those plexiglass dividers. And regardless of how you feel about the way this looks and feels, it certainly helps to reduce the transmissibility. Early detection. The question is, which of those measures are implementable in a country like the US or Europe, whether compared to a country like China? It certainly makes sense to check the temperature of a person going into certain areas and detect people early and don't get people exposed. This might be difficult to implement in the US. I saw an article the other day about the reopening of restaurants in San Mateo, when the original recommendation, they did not recommend to do temperature checks on restaurant patrons out of fear that somebody who was turned away without having the disease could then litigate. There's a social and cultural context for all these measures, but temperature checks like here at the Disney Resort in Shanghai certainly help with the objective of early detection. And then these images have been over the internet quite a bit. I cannot vouch for their authenticity, but I've seen them quoted a number of times. The left one shows for McDonald's takeout the temperature, or a temperature check for the people who handled the food. And on the right side, the map doesn't only show where your delivery driver is, but also the temperature of the delivery driver. It all falls into the category of early detection. And then another early detection is, you might have heard that in China, there is the Alipay health code monitoring, where people have this QR code. If it's green, that's good. And that QR code is basically the ticket to enter certain places and certain areas. Again, I'm not saying that this can be implemented in all countries around the world, but it's certainly an effective digital measure when it comes to the point of early detection and protecting the people in the environment. And then one recent one that originated in Silicon Valley is the notion of mobile phone Bluetooth-based contact tracing. It would be helpful for an effective quarantining if we knew the people that were in close proximity to someone who then turns out to test positive and carry the disease. And what you see here is the announcement of basically iOS and Android, Apple and Google partnering on a contract tracing technology. On the right side, around the same time, is a concept paper from MIT that describes the same concept of a Bluetooth signal-based tracing. So with this, I want to just recap. I believe what we are facing, whether we like it or not, and it's certainly a somber perspective, is that for what could be easily 12 to 18 months, we'll live in a world where we have to practice an active containment of subsequent waves. And because we do not want to have a reopening of our lives and the economy, a reoccurrence of cases, then shutting everything down for another 8 weeks, then try to reopen and shut everything down and have this revolving door effect, we need targeted intervention that preserve our sanity and our lives and our business and our economy, while at the same time being aware that if we do not actively contain the virus, it can immediately go back into exponential growth, as we've seen in Hong Kong and other cases. And that in order to get there, we need a combination of physical, digital measures to get to fewer in-person contacts, lower transmissibility, early detection, and effective quarantining. And then we need the pharma and healthcare industry, and maybe we can help them with some AI-assisted platforms to get to an earlier vaccine or to further develop antivirals. And there's obviously a host of digital platforms that can help to make healthcare services more efficient.